Thank you very much. I'm sure you're familiar with the concept that we all have functional reserves. I was sitting there in the chair and my muscles had functional reserve. Not very much because I'm now 58, but I could have run up the stairs and I would have recruited my muscles. I would have recruited ventilation, oxygenation, cardiovascular function. So functional reserve is an essential component of being a human being or a mammalian species member. What I want to focus on is whether we can understand what functional reserve means and what functional reserve can do for the kidney. Now, in order to do that, you need to understand how to measure kidney function. And obviously, as you know, the kidney has lots of functions. So what function are we actually measuring? Should we measure acid-base control? Should we measure vitamin D hydroxylation, erythropoietin production? Well, the reality is that we don't measure any of them clinically. We only measure small nitrogen-derived solutes because that's all that is cheap and easy to measure. And we use them to make inferences about GFR. And so that is all that we do. That is all that we do. And that's all that's available to us to both measure static function, dynamic function, and recruitable function or functional reserve. But how good are these things that we use to measure GFR and particularly to estimate functioning nephron mass? And the answer is they're dreadful, and you know that. All you have to look at normal human beings and calculate their estimated GFR in the same person on a vegetarian diet and on a high-protein meat diet, and all of a sudden you can almost double to triple the estimated GFR, even though that person's nephron mass is exactly the same. So using creatinine to assess the actual functioning nephron mass is a big problem. And of course, if you want to look at recruitable function, you have to do dynamic measurements, not just static measurements. And under those circumstances, creatinine remains problematic, even if you've got a baseline, because it is modified in the ICU particularly by changes in liver function and changes in muscle mass that take place within the context of critical illness. Then there are other issues which can influence creatinine values in the blood, which make it particularly problematic as a way of measuring dynamic function and recruitability. And finally, it can be dramatically altered by the very things that we do to patients in the ICU, particularly volume administration. How much can we alter creatinine by volume administration? Well, a big deal. A big deal. And this is a very nice paper by Kathleen Liu looking at the ARDS trial database of conservative versus liberal fluid management. So you have a controlled randomized situation, and you can then see how many patients have evidence of acute kidney injury before and after you adjust for fluid balance changes. So that the more positive the fluid balance it is, the more you might expect you would have dilution of serum creatinine and the illusion that your kidneys are doing okay. And indeed, if you look at the adjustments in patients that had a liberal fluid balance versus those that are conservative fluid balance, you can see how you can go from aching stage 1 in 50% of patients to 66% of patients. You're uncovering almost a 30% relative increase in the number of people that actually have AKI, but you can't pick it because that actually had a dilutional effect in serum creatinine, which of course you cannot see in patients having a conservative fluid balance because they're not fluid overloaded and they don't have the dilutional effect. And that's got quite a lot of significance, not only in identifying patients that actually have probable AKI that you cannot pick because they got dilution of their serum creatinine, but it also showing us that in people that are reclassified, the mortality is still very high, much more like those people with real AKI. And so it is telling us that we're not just uncovering a bunch of people that are actually okay and they've got a diluted serum creatinine that doesn't really matter. We're actually uncovering bad people that actually have renal dysfunction, that we've actually missed, that we've actually not identified, and we're not actually able to assess. And indeed, a major associator for mortality is that development of acute kidney injury or the identification of acute kidney injury once you've adjusted for the fluid balance. And that is obviously very powerful. More recently, we just published just now in the Journal of Cardiovascular Anesthesia that this phenomenon applies to cardiac surgery patients even though they're in the ICU for a short period of time. And you can identify in a similar way in this cohort a whole bunch of people that are actually in acute kidney injury, and these people have a greater incidence or a greater identification of acute kidney injury that was not identified before as the fluid balance goes up. And so you're moving literally hundreds of patients after cardiac surgery from the classification of being okay to the classification of having acute kidney injury once you adjust the serum creatinine for the fluid balance of these patients. And again, you're going to say, who cares? So what? Well, the thing is, after you adjust patients, you say, well, you don't have AKI, but now I've adjusted for your fluid balance. You increase their risk of death. You increase the ability to identify people that have got a much greater risk of hospital death, ICU death, and renal replacement therapy, which is intermediate between those that have got AKI without dilution correction and those that do not have AKI. So it's a unique population, and this population has a different mortality, a different time in ICU, a different need for renal replacement therapy, and we're currently missing it because we do not take into account in the assessment of renal function what happens to serum creatinine. So understanding serum creatinine, not only in general, not only in terms of its pathophysiology, but also in terms of its reflection of GFR in the ICU, where people frequently receive intravenous fluids, is essential to understanding what it is that you're dealing with. And so this is fundamental. And if you don't understand that, you're going to get into trouble. And so this is not a reflection of functioning nephron mass. We'll underestimate function, and that's all that we've got to assess functional reserve. Could we use cystatin C then to assess functional reserve, given that serum creatinine is so problematic? Well, first of all, cystatin C costs about 25 times more than serum creatinine to measure, so that's a problem. But nonetheless, when you look at the functional assessment of the kidneys, and you look at cystatin C versus gold standard iohexol assessments of GFR, there's no doubt that cystatin C is superior, if you wish, or it's got a better ability to predict the correct GFR than serum creatinine. That's all very well, and so we would think that cystatin C is cool, then we should move to that if we wanted to assess functional reserve. But there is a problem, and in septic patients, cystatin C dissociates from creatinine in a different way than in normal patients. You can see the change, the difference between cystatin C and creatinine according to body weight increase in patients with sepsis versus normal patients, suggesting that there is a confounder in patients with sepsis that increases cystatin C levels artificially, possibly a reflection in the increase of the release of nucleated cells into the circulation from which cystatin C is generated. So if you have a population with a high incidence of sepsis, and the ICU is such a population, then you have a problem with cystatin C. You're paying 25 times as much to get yourself a signal that could be made unreliable by the presence of sepsis. So you have this really interesting, complex, unfathomable, ever-changing, fluid balance transformed, cystatin C insensitive, sepsis transformed, body weight, body mass, muscle mass transformed signal, and you're trying to, like the old priests of Roman times, to read the flight of birds or the entrails of animals to actually try and work out exactly what's going on in the kidney. And that's all that's available to you in order to see if you can recruit functional reserve. And the functional reserve is the ability to move your GFR from here to there, which you can identify in normal people, for example, as we said before, in vegetarian diets, or even in people with loss of nephron mass, the recruitability may be smaller, but may be able to be identified. And that's all you've got. So we don't really know if there is a recruitable functional reserve in ICU patients, whether it actually exists, whether it can be obtained, and the technology available to measure it is very bad. So that is a problem. Okay. Nonetheless, in this chaotic, insane, poor quality, technologically failing, low-level assessment system, we still have a lot of animal data, a lot of human data, particularly in volunteers, that the administration of animal protein, amino acids intravenously can increase renal blood flow and GFR. So at least in human beings, under optimal operating circumstances, when they are well, you can demonstrate that you can unmask functional reserve. And so now let me take back to the ICU with all the caveats that I've just presented to you, and let's see if we can recruit renal functional reserve. And you say to me, so you've just told me that the creatinine is no good, the cystatin C is no good. How on earth are you going to be able to show me that you can recruit functional reserve in critically ill patients? Well, I'm a trialist, and my answer is always the same, a randomized controlled trial. And you create two situations, a situation where there is no stimulation to functional reserve, a situation where there is stimulation to functional reserve. You use the same technology of measurement, so there is no bias, and you see what happens. And this is what we've just recently done and published in Intensive Care Medicine. We have taken patients, and we wanted to test whether the administration of amino acids given intravenously, standardized and in supplementation to what the patient was normally getting, would alter renal function in critically ill patients as we measure it. What kind of patients were we looking at? Were adult patients. In the first or second day in ICU, they were expected to remain in ICU for at least 2 days at a central line, and through which we could intervene and administer intravenous amino acids, and were not fluid restricted. Now, 235 patients were randomized to standard care, so they didn't receive any amino acid supplementation intravenously. 239 patients received amino acid supplementation intravenously. And this slide is only to show you that the randomization worked, and the patients on both sides of the trial sort of arms were physiologically and clinically essentially identical. So this is the design. This is web allocation, concealed randomization of patients allocated to standard care or amino acid supplementation intravenously. The primary outcome was evidence of acute kidney injury and changes in serum creatinine, and the outcome was available in 235 and 236 patients on each side. This slide summarizes what happened physiologically in these two groups of patients. The patients had their estimated GFR measured every day, and we looked at how the estimated GFR changed over the first 7 days if you received standard care or if you received, quote, recruitment therapy, functional recruitment therapy, which was intravenous amino acids. And you can see there is a clear-cut difference between these two groups with evidence of a degree of recruitment which is about 7 or 8 mils per minute, about 10%, 8 to 10% of function recruitment in critically ill patients in the ICU. And to support that, there is a significant urinary output recruitment with a difference every day of about 300 mils a day and a significant increase in daily urinary output in the patients randomized to receive amino acid infusion. Now, that's great. So you might think, well, we do this. This is really cool, so we can recruit renal function. The doctors will be happy. Fewer patients will get into trouble. We'll have better GFRs, and patients will receive less renal replacement therapy. But in fact, there is a problem. If you give amino acids, you're going to do two things by the look of it. One, you're going to recruit kidney function. Two, you're going to recruit urea generation. So you actually have a renal recruitment and hepatic recruitment. And the hepatic recruitment is beautifully demonstrated here when you can see that despite the fact that these patients now have a better estimated GFR, the urea is skyrocketing up to about 16 millimoles, whereas the control group with worse estimated GFR is actually sitting at about 10. And because doctors can't tell the difference and don't know what's going on and traditionally respond to the urea signal for reasons that are only historical in nature, then you're going to have people worried about people having uremia despite the fact that the eGFR is better. And this slide is really super cool to me. It is cool for two reasons. First of all, it shows that the separation of the two groups with recruitment of renal function is also confirmed by cystatin C measurements. So both estimated GFR based on serum creatinine and estimated GFR based on cystatin C and urinary output tell you that you've made a significant physiological change to GFR in these patients and you've recruited renal function. Of that, I'm pretty sure. But the cool thing is this, that if you estimated GFR using serum creatinine, you think that over time the eGFR of these patients, both groups, has actually got better. Bang! The wrong answer. If you use cystatin C, which is a much more reliable thing and does not depend on the loss of muscle mass that occurs in these patients and therefore in the loss of creatinine generation that occurs in these patients and potentially the movement of creatinine into the urine through the tubular secretion mechanism, your eGFR over time has actually declined. So this is an illusion. This is probably reality. The separation in recruitment is real in both groups, but we are looking at smoke screens and mirrors when we make clinical decisions. So let me finish by saying renal reserve is an important clinical concept. The concept of reserve is a universal pathophysiological concept which has received very little attention, I might say, in clinical medicine. It's real in ICU patients. I think we're pretty clear that we can recruit the kidney to a degree. However, if we look at the static measurements of patients, we can't predict which patients will be recruited or not. If we give amino acids, we can demonstrate that there's recruitment. But then, having done all of this, because we're also recruiting the liver to generate more urea, we actually have no idea what this means in clinical practice and how it would change the management and, of course, the outcome of these patients. Thank you very much.